learners, welcome to this MOOC on population and society. So in the previous module and video, we had discussed the population policies in India and their critical appraisal, module 22. So we shall start with module 23 today, where focus will be on population policies, programs for reproductive and family health welfare in India. So the main objectives of this module is to know the history of reproductive health population policy in India, to get an idea about the policies relating to reproductive health welfare in India, to understand the significance of population policies, to explore the programs of family health welfare in India, and to critically discuss the programs. Let us introduce, dear learners. So we know India is a population of 1.43 billion people and it faces a number of challenges in improving the health and nutrition of its citizens. There have been steady decline in fertility, maternal infant and child mortalities, and the prevalence of severe manifestations of nutritional deficiencies. But the pace has been slow and falls short of national and Millennium Development Goal targets. The likely explanations include social inequities, disparities in health systems between and within states, and consequences of urbanization and demographic transition. There is the problem of reproductive health and child health and nutrition, which are the core priorities for any country, more so for in India with the world's greatest burden of maternal, newborn and child deaths. In 2008, 1.8 million children below the age of 5, including 1 million neonates, died and 68,000 mothers died. India has also the greatest number of undernourished children, with about 52 million stunted children below the age of 5 years. India's public sector program claims to provide a cafeteria approach with a basket of choices. This method mix of program includes 5 official methods: female sterilization, male sterilization, intrauterine contraceptive device IUCD, oral contraceptives and condoms. The history of reproductive health policy in India. So the history is a dynamic tapestry woven with social, cultural and political threads, and over the years India has navigated a complex landscape in addressing reproductive health issues encompassing family planning, maternal health, population control and gender equality. So the early efforts started back in the 1950s and 60s, where India's initial venture into reproductive health policies primarily focused on family planning. The government launched programs promoting birth control and population stabilization, and this phase witnessed the establishment of clinics and dissemination of information about contraceptive methods. Second, we have the emergency era of 1975 to 77, where it witnessed the imposition of a national emergency, during which forceful sterilization programs were implemented. This period remains very difficult due to the coercive measures that violated individual rights, creating a significant backlash against population control initiatives. Thirdly, we have the evolution and expansion of the 1980s and 1990s, when India's approach evolved towards a more comprehensive reproductive health strategy encompassing maternal health, access to contraceptives, and addressing the social determinants affecting reproductive rights. This period saw the introduction of National Population Policy in 2000, aiming to provide accessible and quality reproductive health services. We then have the focus on maternal health 2005 onwards. With a growing acknowledgement of maternal mortality as a crucial issue, India's policies increasingly emphasize maternal health. Initiatives like the Janani Suraksha Yojana, Safe Motherhood Scheme, aimed to reduce maternal and infant mortality by promoting institutional deliveries and providing financial assistance to pregnant women. There is also incorporation rights and empowerment. The recent policies have placed a greater emphasis on women's rights, empowerment and comprehensive healthcare. The focus has shifted from merely population control to ensuring universal access to reproductive healthcare services, including family planning, sexual health and awareness of reproductive rights. We also have, dear learners, the challenges and ongoing efforts, where India continues to face challenges such as regional disparities in access to healthcare, cultural taboos around discussing reproductive health, and the need for effective implementation of policies at the grassroots levels. Ongoing efforts have been implemented, and there is expansion of healthcare infrastructure, enhancing education and awareness, and fostering partnerships between the government, NGOs, and communities. This trajectory of India's reproductive health policies reflect a transformative journey marked by shifts in priorities, approaches, and the recognition of reproductive rights as fundamental human right. With progress and ongoing commitment and concerted efforts, it is essential to ensure universal access to comprehensive reproductive health care for all in India. Dear learners, let us now focus on the significance of family and reproductive health policy. Let us try to understand why is it important. So, we know that it is very necessary in India, and why? Because formulation of such family and reproductive health policy was imperative for several critical reasons, deeply rooted in societal health and economic dynamics. Firstly, population control. We know India has a long grappled with the challenges and its burgeoning population. Addressing family planning and reproductive health became essential to curb population growth rates, which not only strain resources but also impact socio-economic development, healthcare, education, and environmental sustainability. Second, we have maternal and child health. And there was high maternal mortality rates, infant mortality, and inadequate access to healthcare during pregnancy, and these were pressing concerns. A focused policy is necessary to ensure safe motherhood and reduce maternal mortality, improve child health outcomes, and promote institutional deliveries. Third, we have gender equality and women's empowerment. There is reproductive health policies which aim to empower women by providing them with the right to choose when and how many children to have. Enhancing women's reproductive rights and access to healthcare services became crucial in promoting gender equality and women's empowerment. 4. We have healthcare access and equity, and policy initiatives were necessary to ensure equitable access to reproductive healthcare services, especially in rural and underserved areas. Improving healthcare infrastructure, providing contraceptives, and disseminating reproductive health information were essential components of these policies. We also have the human rights perspective, and recognizing reproductive rights as a fundamental human right was pivotal. Policies aimed to protect individual autonomy and ensure that individuals could make informed choices about their reproductive health without coercion or discrimination. 6. We have economic development. The link between population growth and economic development necessitated a policy framework that balanced population control measures with sustainable economic growth. Controlling population growth positively impacts per capita income, education, and resource allocation. 7th, we have social welfare and development. Ensuring the well-being and development of families and communities were central goals, and by addressing such reproductive health comprehensively, these policies aim to improve the overall health, education, and socio-economic status of communities. Thus, in summary, dear learners, we can say that family and reproductive health policy in India were essential to tackle population growth, enhance maternal and child health, promote gender equality, improve healthcare access and equity, uphold human rights, foster economic development, and ensure social welfare and development. These policies formed a critical framework to address multifaceted challenges and create a healthier and more equitable society. We already learned in the previous module the National Population Policy of India. Just a brief summary. It was presented on February 15, 2000, and it provided a policy framework for communicating aims and priorities to various approaches in order to satisfy India's need for reproductive and child health and to achieve total fertility rate by the year 2010. The chief objective of the program included increasing access to and lowering the cost of reproductive health care to everyone and addressing the variety of issues relating to maternal health, child survival, and contraception. India has the largest population in the world, which has surpassed China in 2023. With a current population of about 1.43 billion, population growth control continues to be on every government's agenda. However, the first population policy in India came into force in 1952, and later there has been a lot of evolution of India's population policy, and the long-term objective of achieving a stable population size by 2025 had been introduced. Even before independence, attempts were made to come up with recommendations and solutions to India's burgeoning population problem. So the problem of India with a large population has been since time immemorial. The efforts both pre and post independence are mentioned as follows. We had the Radha Kamal Mukherjee Committee of 1940, and the Indian National Congress appointed a committee headed by the social scientist Radha Kamal Mukherjee to suggest solutions to arrest the population, which had started increasing rapidly after 1921. The committee recommended self-control, generating awareness of cheap and safe birth control measures, discouraging polygamy, among others, as measures to bring down the rate of population growth in India. We also had the Bhore Committee, and the Health Survey and Development Committee under Sir Joseph Bhore recommended deliberate limitation of family as a measure to control the population growth. This committee was set up in 1943 and submitted its report in 1946. India became one of the first developing countries to come up with a state-sponsored family planning program in 1950. A population policy committee was established in 1952. However, the policies framed in the early 50s were largely arbitrary and there was no success. Again, in 1956, learners, a central family planning board was set up and its focus was on sterilization. In 1976, the government of India announced the first population policy, and some of the measures were increased the minimum legal marriageable age for boys and girls to 21 and 18 respectively, providing monetary incentives for employing birth control, improving women's literacy levels through formal and informal channels, and population was made a criterion in deciding the quantum of central assistance to states. Using the different forms of media to popularize family welfare programs, introducing population education to the formal education system. Also, now we shall focus on the emergency period of 1975-77, where coercive measures were used to reduce the population growth, and there were mass forced sterilizations. This, however, backfired, and it discredited the entire family planning program of the government. Again, dear learners, in 1977, after the emergency ended, the new government discarded the use of force in family planning, and the family planning program was renamed as Family Welfare Program. The National Health Policy was adopted in 1983, which emphasized securing the small family norm through voluntary efforts and moving towards the goal of population stabilization. Also, a committee on population was appointed in 1991, which submitted its reports in 1993, in which it recommended the formulation of a national population policy to take a long-term holistic view of development, population growth and environmental protection, and to suggest policies and guidelines in the formulation of programs, and also monitoring mechanism with short, medium and long-term perspectives and goals. Learners, according to the expert group headed by Dr. M.S. Swaminathan, policy was set up to create the draft national population policy. This team finally came, and the national population policy came into force in 2000. The national population policy was unveiled in 1976, back in 1976, and it featured the following things in brief. As a part of this policy, the legal minimum age were 18 and 21 for girls and boys respectively, rising levels of female literacy, increasing awareness of family welfare programs, to reduce the number of maternal deaths to under 100 per 1 lakh births, to achieve a low infant mortality rate of fewer than 30 deaths per 1,000 births, etc. Now, focusing on the National Population Policy 2000, it is the central government's second population policy, which states its immediate objective as addressing the unmet needs for contraception, healthcare infrastructure and health personnel, and providing integrated service delivery for basic reproductive and child healthcare. The medium objective of National Population Policy was to reduce the total fertility rate to replacement levels by 2010. The TFR, total fertility rate, was to be 2.1 children per woman. The long-term objective is to achieve a stable population by 2045 at a level consistent with the requirements of sustainable economic growth, social development and environmental protection. Certain important features of National Population Policy, dear learners, are: the NPP reinforces the vision of the government to encourage voluntary and informed choices and citizens' agreeability in order to achieve maximum benefits from reproductive health services. making school education free and compulsory up to the age of 14 years and also reducing the dropout rates of both boys and girls, decreasing the infant mortality rate IMR to under 30 per 1,000 live births in the country and to be achieved by 2010 as prescribed by NPP was brought out. Reducing the maternal mortality rate MMR to under 100 per 1 lakh live births to be achieved by 2010 as prescribed by NPP was also brought out. Achieving universal immunization for all children against vaccine preventable diseases. Also to encourage delayed marriages for girls, preferably before 18 years and above 20 years. Achieving 80% institutional deliveries and 100% deliveries by trained persons, attaining 100% registration of pregnancies, births, deaths, marriages, making available universal access to information, counseling, and services for fertility regulation and contraception with a huge range of choices. Also, dear learners, it focused on containing the spread of AIDS, boosting better coordination between the management of reproductive tract infections, RTI, and sexually transmitted infections, STI, and the National AIDS Control Organization, NACO, preventing and controlling communicable diseases, integrating Indian medicine systems, Ayush, in reproductive and child health services, vigorously furthering the small family norm, bringing about a convergence of all related social programs so that family planning and welfare becomes a people-centric program. The NPP 2000 is different from the previous population regulation policies because for the first time here, a combination with child survival, maternal health, women empowerment and contraception issues were seen together. In other words, the India's NPP is a comprehensive framework that addresses the country's population dynamics, aiming to achieve sustainable development, societal equity, and individual well-being. Enacted in 2000, it outlined strategies and goals to manage population growth while ensuring reproductive health and rights. Now, the key facets of the national population policy include: the policy aims to stabilize India's population by addressing high fertility rates through voluntary family planning services, education, and access to high range of contraceptives. The focus is on reducing the TFR and to replace it by 2045. We have the reproductive health, which ensures reproductive health and rights as its pivotal aspect, and the policy emphasizes the need for accessible and quality healthcare services for maternal and child health, including antenatal care, safe deliveries, postnatal care, and addressing reproductive health issues. We also have the gender equality and empowerment, which recognizes the importance of gender equality. The policy stresses the empowerment of women, ensuring their reproductive rights, education, and access to healthcare. It aims to eliminate gender-based discrimination in matters of reproductive health and decision-making. We also have learners, the adolescent health and education. The policy recognizes the significance of addressing the reproductive health needs of adolescents. It emphasizes education on sexual and reproductive health, aiming to empower young individuals with knowledge and access to services for informed decision making. We have population and development linkages, which recognizes the interconnection between population dynamics and socioeconomic development, and the policy integrates population concerns into development programs. It underscores the importance of ensuring that population issues are addressed in developing planning. There are also partnerships and implementation. The population policy advocates for collaborative efforts between government agencies, civil society, NGOs, and international organizations to ensure effective implementation. It stresses the need for resource mobilization, capacity building, and monitoring and evaluation mechanisms. There are also ethical considerations, and this upholds ethical considerations, human rights, individual autonomy in matters of reproductive choices, and it forms a fundamental aspect. The policy emphasizes voluntary and informed decision-making in family planning and reproductive health matters. Now, dear learners, let us focus on some of the policies and programs for reproductive and family health welfare in India and their details. First, let us discuss about the National Rural Health Mission, NRHM. So, under NHRM, the Government of India has taken steps to improve maternal health. The three key efforts are encouraging delivery in institutions through incentives from Janani Suraksha Yojana, supporting the development of services for emergency obstetric care, and training auxiliary nurse midwives and nurses for 2 to 3 weeks to gain competence as skilled birth attendants. We also have the Child Survival and Safe Motherhood Program, the CSSM. Until the advent of the National Rural Health Mission, NRHM, in 2005, the programs for maternal and child health planning were mostly fragmented and inconsistent. India lacked the comprehensive overview of the needs of focused communities, outreach programs, etc., due to inadequate health systems and low political visibility. With the launch of the Child Survival and Safe Motherhood Program, CSSM, in 1992, there were interventions for child survival, immunization, diarrheal, disease control, acute respiratory infections, newborn care, and maternal health, antenatal institutional deliveries, emergency care, etc. In 1997, the Program for Family Planning and the CSSM program were merged to create the Reproductive and Child Health Program. This focused on reproductive and child health, which shifted to births in institutions and emergency obstetric care as the key strategy for reduction of maternal mortality rate. We also have the ICDS, Integrated Child Development Services, which was launched in 1975 as an Indian government welfare program which provided food, preschool education and primary health care to children under the age of 6 years and their mothers. Services provided by this program include supplementary nutrition, non-formal education, immunization, health checkups, referral services and nutrition and education. These are provided as a center called the Anganwadi that is located within the village itself. The Anganwadi worker, a woman selected for the local community, is the key functionary. She plays a pivotal role, and with assistance from a helper who is responsible for the population of an average village, which is about 1,000 people. We also have the RCH, Reproductive and Child Health Program. This is a comprehensive sector-wide flagship program under the umbrella of the Government of India's National Health Mission to deliver the RCH targets for reduction of maternal and infant mortality and total fertility rates. The RCH program aims to reduce societal and geographical disparities in access to and utilization of quality reproductive, maternal, newborn, child and adolescent health services. Launched in April 2005 in partnership with the state governments, RCH is consistent with Government of India's National Population Policy 2000, the NHP, National Health Policy 2001 and the Millennium Development Goals, MDG. The 6 components of RCH programs are maternal health, child health, nutrition, family planning, adolescent health and PCPNDT. Now we shall focus on another scheme, which is the Janani Shishu Suraksha Karyakram, JSSK. This is a scheme launched in 2011 to provide service guarantee in the form of entitlements to pregnant women, sick newborns and infants for free delivery including caesarean section and free treatment in public health institutions. This include free to and fro transport between home and institutions, diet, diagnostics, drugs and other consumables and blood transfusion if required. We also have the family planning program, which was launched in 1952 to help women achieve desired family size and to avoid unintended and mistimed pregnancies. The family planning also helps to reduce maternal mortality, infant mortality and abortion significantly. Such planning is influenced by factors such as unmet need, age at marriage and first childbirth, and spacing between births. And also the Government of India has committed to achieve certain targets by 2017, such as MMR to 1000 per lakh birth and infant mortality rate to 30 per 1000 live births and total fertility rate to 2.1. We also have another program of reproductive, maternal, newborn and child adolescent health, RMNCH plus A strategy, which is a strategy built upon the continuum of care concept and is holistic in design, encompassing all interventions aimed at reproductive, maternal, newborn, child and adolescent health under a broad umbrella and focusing on the strategic life cycle approach. This strategy was launched in 2013 and is based on the principles of convergence, equity, gender, human rights and accountability. The RMNCH plus A strategy aims to address the major causes of mortality and morbidity among women, children and adolescents, as well as delays in accessing and utilizing healthcare services. Learners, we shall now focus on the Mission Indradhanush. So this is a program launched in 2014 to accelerate the full immunization coverage of children and pregnant women in the country. Mission Indradhanush aims to cover all those children and pregnant women who are either unvaccinated or partially vaccinated against 7 vaccine preventable diseases: diphtheria, pertussis, tetanus, polio, measles, severe form of childhood tuberculosis, and hepatitis B. Mission Indradhanush also provides a vaccination against Japanese encephalitis and Haemophilus influenza type B in selected districts of the country. This mission follows a systematic approach of identifying and tracking the left out children and pregnant women and mobilizes the health workers and community volunteers to ensure their immunization. Learners, next we have the Rashtriya Kishore Swasthya Karyakram RKSK. This is a program launched in 2014 to address the health and development needs of the adolescents in the country. It adopts a holistic approach to adolescent health, which includes physical, mental, and social well-being, and has 6 strategic priorities, namely nutrition, sexual and reproductive health, non-communicable diseases, substance misuse, injuries and violence, and mental health. This program focuses on strengthening the adolescent-friendly health services, creating a supportive environment, enhancing the skills and capacities of adolescents, and generating evidence and strategic information. We now shall discuss the PMSMA, Pradhan Mantri Surakshit Matritva Abhiyan. This is a program launched in 2016 to provide quality antenatal care to pregnant women on the 9th of every month. PMSMA aims to ensure that every pregnant woman receives at least one checkup in the 2nd or 3rd trimester of pregnancy by a qualified doctor. It aims to identify and follow up the high-risk pregnancies and provide them timely referrals and management. It involves the participation of private sector doctors who volunteer to provide free antenatal services at public health facilities. We also have the Pradhan Mantri Matri Vandana Yojana, PMMVY. This is a program launched in 2017 to provide cash incentives to pregnant and lactating women for the first living child of the family. It aims to provide health and nutrition status of women and children and reduce maternal and infant mortality. Provides a cash benefit of Rs 5,000 in 3 installments upon fulfilling certain conditions such as registration of pregnancy, institutional delivery, and completion of first cycle of immunization of the child. PMMVY also provides a cash benefit of Rs 1,000 under Janani Suraksha Yojana, making the total benefit amount to Rs 6,000. Thus, learners, this family health welfare program in India have aimed to improve healthcare accessibility, maternal and child health, family planning, and overall well-being. While these programs have made significant strides, they also face certain challenges and that require critical appraisal. First, there has been successes in maternal and child health. We also have family planning initiatives, healthcare infrastructure. There are challenges in urban areas, inequities and accessibility, and quality of healthcare, including health awareness, education, community participation, and accountability. So, a critical appraisal should consider these aspects to further strengthen family health welfare programs in India. Strategies focusing on improving healthcare infrastructure, addressing regional disparities, enhancing community engagement, and ensuring quality care provision can contribute to more effective and inclusive health programs. Few concluding remarks. It has been observed from various studies that family planning services may be de-linked from any population policy. There is enough empirical evidence that increased spacing between births and limitation of family size contributes not only to improvements in living standards, education of children, and health of all family members, but also serves as a catalyst to accelerate economic growth and poverty reduction. But the goals of any economic policy should not include specific component of fertility reduction and targeted number of family planning acceptors. The fact that family planning provides an opportunity for couples to realize their development aspirations is a justification in itself for revamping the program on the lines suggested above. For many smaller countries, this number would be universal coverage, but in India it is more than 10 times fewer than the number of trainees needed in just the high burden districts. The reason for slow implementation, aside from numbers required, include lack of capacity for training and supervision, lack of ownership by and convergence with the integrated child development services, lack of review, referral component, non-availability of line supervisors, etc. Besides, facility-based care of infants and children has also not been given enough attention. So thank you so much. The next module will be module 24. Thank you.